Well, the rationale behind the trial is that thermal ablation is associated with a much lower adverse event rate. So it's less invasive. The complication rates, according to retrospective series prior to the study, were in favor of thermal ablation. But in the old days, thermal ablation just had too many local recurrences. And with all the technological advances over the last 2 decades, thermal ablation is now, for the small tumors, competitive to surgical resection. So why are we doing this non-inferiority trial? We wanted to see if you eradicate the lesions with thermal ablation, would you be just as effective in eradicating the disease, and also would you be just as effective with regards to long-term overall survival, but with a lower number of serious adverse events. That's the trial. So when comparing the two arms, it actually compared really well to what we knew from the retrospective literature. Thermal ablation had a significantly lower mortality. There were 3 fatalities in the surgical resection arm, and there was 1 90-day mortality in the ablation arm, but that was unlikely related to the ablation. But also the lower grade complications were far lower with thermal ablation. So indeed the trial supports the idea that thermal ablation is less invasive. The hospital stay was significantly lower because with percutaneous ablations the patients can go home the next morning, and following surgery they are admitted to the hospital multiple days. We are still assessing the cost effectiveness and the quality of life issues, but it's much less invasive, and with a lower number of complications and also a shorter hospital stay, our guesses are that thermal ablation is associated with a superior quality of life and also a superior cost effectiveness ratio because it is cheaper than surgery. So it's difficult to tell because this is for the future. So I presented the results of the clinical results of the trial. So we're working on the cost effectiveness, but you know it's not an easy. It's not a difficult question to answer, given the fact that the complication rate is much lower. They go home the next morning, so I'm guessing that also the cost effectiveness ratio will be positive, because following surgery it takes longer before they can go back to their normal day lives and to their work when compared to thermal ablation. But we have to do those analyses. Well, if you ask me, the simple answer is yes. But what is important to realize here is that both for surgical resection as well as for thermal ablation, it has to do with expertise and operator dependency. So if you are in a center with a high quality surgeons and high quality interventional radiologists performing high quality surgery and high quality ablations, then I would say yes, thermal ablation is associated with a superior safety profile, shorter hospital stay, and presumably a superior quality of life and cost effectiveness ratio. But we do not know for less experienced centers if the same goes. So I think the next task that we have to train everybody to do a good job, both with the resections but also with the thermal ablations. I think for the patient group that we assessed, so that is patients with a limited number of colorectal liver mets that are small in size, we need to know if let's say the real world situation compares well to our trial situation. So there's a lot of prospective registries out there, single arm, looking at how good do less experienced centers do regarding thermal ablation. If they do just as good, then I think that the standard of care for small liver tumors, small colorectal liver mets, identical to primary liver cancer, should probably be thermal ablation and no longer surgical resection.